Hello, everyone. Thank you for joining this session dedicated to the new healthcare pathways for patients. And it's my pleasure to invite Peter Wallace, who is a partner at Deloitte, and Alex Mata, who is International Operation Director at Teladoc. And Peter, just to start, we have defined that, there are new healthcare pathways, and maybe digital has definitely improved a lot of the pathways, healthcare pathways. Can you describe what you see and maybe have some focus on how digital is really modifying the healthcare pathways in the future?
Yeah, for sure, Francois. So thanks first of all for having me join. Just in terms of context, I'm a partner at Deloitte. I work in the life sciences space, but primarily in biopharma and a little in medtech. I'm also in the technology practice, so I work with the clients to figure out how technology can enable and drive their business forward. And obviously, the whole digital agenda is one which is front and center of the industry at the moment, and patient support programs is a key part of that. So, but to your question, I think it's useful just to frame that question more broadly in terms of where the industry is going and where technology is taking the industry. So we just go forward a slide. So Deloitte has produced a point of view called The Future of Health, which looks forward. It was published in 2019, so it looks forward 21 years, which is 3 innovation cycles, and really tries to paint a picture of how the world might be 3 innovation cycles out from a technology perspective, and then paints a picture of how the healthcare ecosystem will be different. Now, clearly, it's not a prediction. I wouldn't be that bold, but I think it is a useful paradigm about which to think about how technology is changing the healthcare ecosystem. So there are 3 trends I'd call out as underlying drivers of this shift. The first one, I think, is one which people recognize, which is the proliferation of data and the ability to run analyses on that. And those data are wide and varied, and some of them are pharmacological, some of them are healthcare based, some of them are environmental. But the data are now available in a way which wasn't the case some years back. And more importantly, the ability to run analyses and develop algorithms to interrogate these data is also increasing and available in a way that it wasn't in the past. The second of those first drivers is around the term which is often referred to as consumerization of healthcare. But effectively, it's all about the patient being at the center of the healthcare pathways, as opposed to the physicians. So historically, the HCP, the healthcare physician, was the person who controlled what happened with the patient. And patients were somewhat passive. They did what they were told. The physician diagnosed a condition, made a recommendation, surgical, pharmacological, whatever, and the patient did as he or she was told. Increasingly, we're seeing a world where the patients have agency, and the patients will engage more proactively in the management and treatment of their health conditions. Some of those could be preventative, some of them are tied to treatments. But that deconstruction from the HCP and reconstruction around the patient is that second trend. And then the third one, I think, which is also important to think about, is that and this is particularly true from an insurance or payer perspective, healthcare will be delivered not in large payments, but in much smaller increments. And by that I mean, if you take something today as simple, take something today like cardiovascular disease. Somebody has a heart attack, somebody has a stroke, they get hospitalized. That triggers a big payment. In the future, because of the ability to understand disease pathology better, to understand lifestyle factors, to engage earlier and prevent the acute event that caused hospitalization, effectively that's where the payments will come. So it's the idea of these smaller interventions earlier in the condition of the disease's pathway, preventing the significant acute events which drive much of the cost in the system. So that's a sort of a quick view in terms of where healthcare will be in 2040. So let me go down one slide and think about what that means for the players in the ecosystem. And what the trend you'll see is the mass produced, or the mass solutions, we believe will disappear, and it'll be much more customized to individual patients. So again, from a provider perspective, the big monolithic general hospital that treats everything from diagnostics to post-operative, end of life, all of those capabilities been delivered out of a single hospital, I think will be a thing of the past. It'll be much more to providing care where the patient or the customer, the individual is. So care in the community, localized care at home, right? And preventative, focus on prevention rather than cure or treatment, will put the end of those big hospitals. I'll come to insurance in a second. The same is true from life sciences. The idea of the one-size-fits-all treatments, again, I think will change. And as we understand disease pathology better, as we understand genomics better, pharma companies will increasingly be developing therapies which are designed for a cohort of one. So pure personalization with the focus on prevention and cure rather than treatment of disease. And then from an insurance perspective, again, comes back to this idea of how medical financing happens, right? And again, the focus will shift to more personalization in terms of what people insure, better understanding of somebody's individual risk profile, better understanding of genomics and predisposition to disease, better understanding of environmental and lifestyle choices will allow you to be more targeted in how you finance medical interventions, and again allow you to really focus in and target at an individual level. And the final point I would say, and this is particularly true here in Europe, the government, the public sector will then act really as this catalyst or this enabler to take us on that journey. Clearly the US is a different market given the uniqueness of their healthcare environment, but certainly in Western Europe, there'll be a key role for government in driving that forward. So let me jump forward one more slide, and then I'm going to go on to PSPs very quickly. Clearly, our future of health is a hypothesis, right? We've painted a picture of what we think the world will look like 20 years out. But there are a couple of things which I think are important to call out in terms of necessary conditions to enable that future to realize. The first two on this slide around data sharing and interoperability of data. I mean, clearly in Europe, access to patient information, patient data is more challenging than it is, say, in the United States. But as the patient becomes more empowered, a fully consented model where patients willingly share information because there's a very clear benefit in doing so, we think will come into play. And that will address some of the challenges we have today in terms of access to patient data. Bulk access to patient data without consent, I don't think will work, certainly not in Europe. So there will be the evolution of an environment whereby people willingly engage in the system, with the system, share their data because there's clear benefit for them in doing so. That then speaks to interoperability in terms of how data can be connected across the ecosystem and the environment. The fourth one over I'll also call out again is this idea of the empowered consumer. And again, this is where this will be driven by people, individuals, demanding transparency, demanding convenience, demanding access to health interventions. And then the final one I'd call out on this one is around this behavior change, which really is about technology in terms of things like AI, VR, augmented reality, transforming how health care is delivered. So let me jump forward to my last slide, and I'm going to talk now specifically about patient support programs. So most people, I think, are aware of PSPs, but just in case, let me quickly define what we mean by a PSP. A PSP basically is a wrapper you put around a therapy. So if you're a pharma company producing a disease to manage diabetes, right? That's a pharmacological intervention. You put the support program around that to augment that therapeutic pathway and improve the overall patient outcome. What you see on the left-hand side of the slide are a number of various interventions that or if you have building blocks that can comprise a PSP as it is imagined today. Clearly, these could evolve and more things will be added in the future. But today, these are the sort of things which form the building blocks of a patient support program. So the key point is that you integrate the pharmacological and non-pharmacological interventions to give you a holistic patient pathway which delivers you a better patient outcome. From a pharma company's perspective, it also allows you to drive differentiation and build trust, both with the patients and with the healthcare practitioners. Now, this is obviously a challenge today for pharma companies because the level of trust, I think, is unwarrantedly lower than it should be, given the benefits that they deliver to the population at writ large. As we've seen in the COVID pandemic, I think it's, if that doesn't bring into sharper relief the value and the benefit of the pharmaceutical industry, nothing will. Nonetheless, there's a trust deficit today. So the PSP is one way of trying to build that trust and actually integrate the various players in the healthcare system together. And then, very importantly, because healthcare is expensive, they do give you a platform that you can scale and then ultimately optimize the cost to deliver. So that's what we mean by a patient support program. It might be useful to talk through what an example of one might be like, Francois. That would be a useful place to go next. So you'll see PSPs. So there's various types. Some of them will focus on chronic conditions. Some will focus on acute conditions. So you'll often see a PSP put in place for an oncology therapy. The ones which focus on the acute conditions are, in my experience, and somewhat around managing the workflow. So how do I schedule the interventions? How do I schedule the tests? How do I follow up with the patients? How do I book in for an infusion, etc.? So they're quite time bound, and they serve a particular need. A more interesting one, I think, is where we look at, and this plays also to the longer term view of curative or preventative interventions. We have a chronic condition. So if it's something like diabetes, if you've got something like rheumatoid arthritis, if you've got any condition which is today is at least non-curative, but does impact significantly on individuals' quality of life. There, I think the PSP comes into its own because it really does start to integrate not just a pharmacological intervention, but it looks at things like, what is the right treatment pathway for a patient? How do we design and build a plan which is optimized or tuned to an individual's needs? At the very start of this would be the enrollment. How do we get patients onto a PSP? And that comes then, informed consent is obviously a key part of that. Access is often a challenge, right? How do we ensure that the patients have access through, particularly if it's not on a standard formulary list? There may be copay, there may be well, there wouldn't be copay in Europe, but there may be private insurance which is funding it. We then set up the program, and it's about a personalized patient journey. You figure out what are those support services you need to integrate. What does the care network look like, right? Can you treat the person locally at home? Can you send nurse practitioners to the house? Do they have to come to the hospital? Do they go to a clinic? All that needs to be designed and then operated through the PSP. And again, something like diabetes is a good example where much of the care can be delivered outside of your hospital, right? And the intention there is to prevent the acute event which brings somebody to hospitalization. Communication management. How do I educate? How do I advise? How do I deliver nudges in terms of some of the lifestyle choices and behaviors which can dramatically affect the quality of life of a patient? How do we optimize the patient experience, right, in terms of particularly data providing information and insights to patients? And that can be integrating things like your Fitbit for pedometer, or it could be integrating your Apple iWatch or your heart rate monitor or your sleep monitor. All these things you can bring into the program, and we've done that with pharma companies, particularly on diabetes care. And then obviously that sort of ongoing engagement. And if there is an acute event which starts this, then will be a trigger to ongoing transition management. But all those things are delivered through a digital platform, integrating various data, both from the patient data, but also other devices, as I said, wearables and such like, but allow you to actually build that picture and manage the patient through the pathway. So let me pause there. That's, I think, all I wanted to cover on the slides, and we can take a couple of questions, I guess.
Thank you, Peter. Maybe just before moving to Alex, I have two different questions. The first questions relates to your first slides, where everybody agrees that we move from a cure to care condition. Everything will be as a prevention. But my question I have here is that, to my knowledge, there is very little investment in prevention, very little economic model for prevention. And even though we want to move to prevention, except in COVID, of course, crisis, but for other sickness, there is very little investment made on prevention, whereas I have no figures, but I guess it's 99% on cure and maybe 1% in care. And so it's very difficult to imagine the switch of paradigm that we will need to do to switch from cure to care.
Yeah, so I would have a slightly different view on that one, Francois. So again, I don't think it's going to be a binary switch where it suddenly be changed from one state to another state. It will happen gradually over time. And I think we're seeing it happen already. So if you look at the debate, certainly here in the UK, around care in the community, right? So there's been a big drive over the last probably 10 years to try and reduce the amount of care delivered in big hospitals, right? Because A, it's really expensive. It's probably the biggest driver, and it's not sustainable. And also, it's not convenient for the patients, and there's also risk of cross infections. And people, I mean, the pandemic brought us into sharp relief. People were in hospital with other conditions; they get COVID, they die of COVID, right? And that's always a risk when you bring people together into an area. So, I think you're already seeing a shift, which is how do we deliver care away from those big monolithic general hospitals, right? And then once you're on that journey, the discussion then becomes one of, okay, so if I've been diagnosed with hypertension, they put me on statins, and the GP is monitoring that, and I'm aware of that. The next question then says, well, okay, how about lifestyle change? Well, actually, we need more exercise, reduce salt in your diet, whatever it might be. You're starting to engage in a conversation with the patient around preventing the acute event, the stroke or the massive coronary event. You're also seeing with younger people, right? I speak as someone, my father had a stroke. So I'm very well aware of the dangers of hypertension. So I'm monitoring this, and the regular checks you're monitoring. And so I think it's a behavior change, but I think it'll be driven not by the system, it'll be driven by the consumers, by the patients. And this goes back to the point about the patient moving from a HCP-centered solution to a patient-centered solution. The patients will drive the change because the choices they make and the services they demand will force the system to adapt and change. Now, that's my view. Right? That's my opinion. I mean, clearly, if I could forecast the future, I'd have a much more lucrative career on the stock market. But that's where I think the direction of travel is for the industry.
And forecast the future is difficult because nobody had forecast the COVID crisis anyway. But now coming back to PSP, the interesting thing is that we do see that now when giving a therapeutic treatment and etc., most of the time now it is built with a digital companion or digital app, or there is digital something with the treatment, which definitely is very interesting, because you mentioned that you have devices, connected devices. Everybody has a smartphone, so which is a device that collects data. We can do real life studies. So, and now, do you believe that the support of a patient during any treatment will be maybe 100% of the time together with a digital companion? And how do we, again, the economic model of providing the therapeutics and the digital companion, how do you think it would work?
So I think much of the clients I've worked with, actually, let me think, of the pharma companies I work with at the moment, all of them have a stated policy which says for every new therapy they bring to market, they will bring a digital service alongside it, right? And it's digital by design. And they're also looking at, from a clinical trial perspective, before it even gets to commercialization and marketing, from trial setup and design, again, they're increasingly using digital platforms to support that. So I think that direction of travel is set already. The question really becomes one, in my mind, of how best do you improve the care pathway using digital tools. So education in of itself, I don't believe is sufficient to change behaviors, right? So, you know, people have known for 30, 40 years, 50 years that smoking is bad for you, right? And while numbers of people smoking has gone down, it hasn't been eliminated. And it's very hard to say, if everybody behaved rationally, nobody would smoke, right? But people still do. Likewise, obesity, right? Everybody knows the health risks about it, but it's hard to change behavior. So I think the interesting question would be more about, how does technology modify the behavior? And it's beyond just telling you facts. It's about nudges. It's about changing. It's about changing habits, right? So there are. I mean, I have a Fitbit, which, if you're sedentary for a period of time, it just vibrates, right? It's a small little nudge, but it vibrates, reminds you to get up and move around, right? If you had, if you had devices that could, I don't know, monitor heart rate in real time, there's all kinds of things you can imagine you could design interventions around. But for me, the key point is, the key opportunity is how you build it into the treatment pathway in an active way rather than a passive way. So it's not just about providing you data, it's about actually constructing and building nudges, behavior modifying interventions that will help you deal with the treatment and actually prevent you getting acutely ill in the first place.
Okay, very, very interesting. Maybe I can move to Alex, and we will come back to you, Peter, with one last question. Alex, you are part of Teladoc, and you have been working for years in patient support programs, now digital patient support program. I guess there is a tremendous change in habits. Can you describe the changes that you have seen these years?
Yeah, sure. Thank you, Francois, for inviting and participating into this session. And thank you, Peter, for all your explanation. So during these last years, we have been digitalizing most of the parts of the patient support program. As Peter mentioned, there are several parts in the journey of a patient. So basically, real examples, right? So some years ago, the enrollment process of the patients was done by physical documents where they have to send by post, including consents, etc. Right? So today, we are able to offer this using easy digital solutions, using an app, using a web portal to manage this complex process. Because from a legal point of view, you need to be sure that you capture well all the information from the members, right? And the consent to be part of these programs. What we see is that today a trend is that typically these programs today are linked to medications that include a device, right? For example, biological therapies with auto-injectors. So based on the experience we have, the majority of these patients are afraid about the injection process, right? So this is something that they are not used to do. So they will need here a support from patient support program. So before the pandemic, one of the options that we were able to deliver, and it was in Peter's slide, was the possibility to send a nurse to patients' home to do the training on the injection process, right? So the pandemic just accelerated these changes in this process, and today we are able to provide this solution virtually. So we have the nurse sitting in the office or at home, and the patient at home, so they are able to do this training using technology, using a video consultation. What we have seen is that patients are really open to use these new processes, new tools, and the experience that the patient and the nurse are having is extremely good. So they are really satisfied with the usage of technology in this part of these processes. Another key improvement that is coming are the connected devices that both of you already mentioned, right? So today we are able to capture data from some devices in real time. So we are listening companies talking about connected pens, talking about glucometers that are using cellular connectivity, meaning that, for example, a diabetic patient that is using a glucometer, uh, in question of seconds, we could have this data on the cloud. And first of all, where we are able to iterate, to integrate this data and be able to provide nudges, and as Peter mentioned, to help with the patients to change the behavior. But also we could have a team of nurses, of coaches behind that is monitoring and supervising that all the measures are okay. So this is a trend that we are seeing. As Peter mentioned, pharmaceutical companies are this is part of their own the new medications, okay? And with this data, what we are able to do is to help patients in real time. So combining with AI technology. So having millions and millions of data, we will be able in the future to do some predictivity models and to help patients, help in avoiding to suffer acute conditions.
Thank you, Alex. Maybe Peter, I see the time flies as usual. Just maybe my last question to you, Peter, is considering the evolution of medication, the evolution of you mentioned that you work in life science and biotech companies and so on. So we see a more and more personalized treatment, more and more customized treatment. Do you think what is the role of the an AI and everything connected device? So if we push the system to a point where we can maybe say that the patient could be autonomous in the future with AI, and so no more doctor anymore. What do you think about the new role maybe of doctors in this environment that is moving?
So there's a couple of things I'd call out, and I'll answer the question about the role of the doctor in a moment. But just one of the benefits of the current healthcare setup is it's easy from a payment perspective. It's easy to understand, right? Someone gets hospitalized, they incur the cost gets funded either through the healthcare, through insurance, through the government, or whatever else. The challenge with preventative medicine is it's really hard to agree a funding model, right? Because health systems are reluctant to pay for something that didn't happen, right? Now, so one of the challenges is, how do I say to a health service, a national health service, or a private insurance company, these interventions have allowed you to avoid the big cost of hospitalization for an acute event because we've had these small payments up front to prevent, right? Now, and that's always been a challenge. So, but in the future model, as the analytics improves, as people's understanding of genetic predisposition improves, as people understand about the direct contribution of environmental factors to episodes improve, your algorithms can model that to a level of accuracy against a big enough population that you can actually make that funding model work, right? Which I think is the first thing. Now, the second point about the role of the physician, I don't foresee a world where we no longer need doctors, right? But I do see a world where we might not need as many of them, and particularly the role of the general practice physician. I think that may well change, right? Because if you think about, today, a general practice physician is often a gatekeeper to the secondary care system, right? So somebody presents at a physician with non-specific symptoms, and it's a bit of an iterative process. It might take weeks, months, years before you get to a diagnosis of what the underlying condition is, right? That's typically true of things like Alzheimer's diseases in there that I've done some work around. I would posit that an AI, in terms of that initial diagnostic or triaging, once you have these data, you can start to understand genetic predisposition, you can understand environmental factors. You could use an AI which would vastly speed up that diagnosis, that first triaging before you get sent to a specialist for a CAT scan or an MRI or whatever it might be. So I do see a role of AI augmenting what the physician does. I don't see a world where we no longer need doctors. At least not in my lifetime, I don't think. But who knows? I mean,
no, certainly we will need doctors, but they will certainly play a different role. Yes. And have different tools. Alex, please, if you want to say a final words as a conclusion of what we do at Teladoc.
Okay, yeah. So in Teladoc, we are providing several services and trying to help members around the world. So in some of the countries, we work close with some patients that are suffering several conditions like diabetes, like hypertension, some cardiovascular diseases, etc. We had always tried to combine technology and doctors. So we think doctors are going to be needed for sure. So, and what we are trying to do in the management of chronic conditions, for example, is to have on real-time data to be able to, based on that based on all the data that we are capturing from all the patients, to be able to bring personalized nudges and personalized programs to the members in order to change behaviors and in order to improve their disease and be able to manage themselves.
Thank you so much, both of you, and enjoy your day.
Excellent. Thank you very much.
Thank you.